Okay, very good
Yes,
evening, my dear students. We're going to start the class on liver applied physiology and the so-called liver function test. And liver problems are very common nowadays because of the infection and alcohol. And most of the decompensated liver patients are coming for more than 10 to 20% of the liver decompensated patients coming for elective surgeries. And we should have the knowledge regarding this physiology. That is the applied physiology of this deranged liver function and how to assess the functional status of the liver. That is most essential for the anesthesiologist are concerned. That is why we are starting this topic today. That is most of the time the students are so much feared to present the liver case, and today I will clarify the areas of basic things first, and then we can discuss in detail along with the case discussion during the hours of case discussion. Okay. And now we can start with the first slide. And as far the anatomy is concerned, I don't want to go into the every details of anatomy. That is not at all needed for our anesthetist. I go into the very salient points. As far as the anatomy is concerned, liver has only 4 lobes, and this falciform ligament that splits the liver into right and left lobe. And the right lobe has another 2 lobes, one is called caudate lobe, and this one is caudate lobe. And for the surgeons are concerned, they are most bothered about this, never bothers the lobes of the liver, they are most bothered the surgical segments. Because these are the segments they are most bothered because they are so much interested in partial hepatectomy. How to remove, what are the segments to be removed. And there with this anatomy, this surgical anatomy of the liver, dividing these surgical segments of the lobe, our hepatic vein has the landmark for it, and then this divides into middle hepatic, left hepatic, and right hepatic veins. And with this, there's divided these into 4 segments, and with the portal vein for this bifurcation, these 4 segments will be further divided into 2. That is by left side, by the left lateral section, that is upper and lower, and left medial section, that is upper and lower, by this anatomical location of this portal vein. And for the right side, it is right anterior and anterior section by upper and lower, and for the right posterior section, that is by the upper and lower. Totally, there are 8 surgical segments where the hepatectomy is going on. Up to this, liver, you can remove 70% of the hepatic tissue, and the liver can have the capacity to regenerate and come to normal size within a matter of 3 to 4 months. That is the very greater capacity of the liver to regenerate. This is for the surgical segments and anatomical lobes are concerned. And this is the liver has the 2% of the body weight. It's a very large internal organ in our body. And it is a weight about 1.5 kg, and the functional unit of the liver is called lobules. And lobules, we have to have the knowledge regarding this functional unit of the liver that is called lobules. They are about 2 millimeter, and what you are seeing this picture is the liver lobule. That is 2 millimeter in diameter and 0.8 to 2 millimeter in diameter, and roughly about 50,000 to 1 lakh lobules are present in the liver. And see this lobule, we can go to one by one. That is most important for our anesthetic point of view. We have to understand the physiological anatomy of this liver lobule. I think you can all have read about this liver today. I don't know, I hope that you can follow me. First is the central vein. The central vein ultimately drains into the hepatic vein. ultimately drains into the hepatic vein. It is not there in the picture. Okay. The central vein has on either side from this central plates. Here from this central vein, there are two plates of liver cells. See this, two plates of liver cells that radiate from the central vein, and between the adjacent cells, there is an biliary canaliculi. See this biliary canaliculi. See this biliary canaliculi. In the adjacent, these two sets of plates of liver cells, there is an biliary canaliculi. It is in between the two sets of biliary canaliculi, and it supplies biles into the bile duct. There is a bile duct, okay? And next one is the small portal venules. There is a portal vein. There are small portal venules that receives blood from the GIT, gastrointestinal system, okay, via this portal vein, and hepatic cells are continuously exposed to these portal veins and forms your sinusoids. Okay. And with these sinusoids, there are endothelial cells, and these portal veins, venules, then to the sinusoids, and with these sinusoids, it ultimately drains into the central vein, and ultimately it goes into the hepatic vein. There is a system arrangement in the blood. So whatever the blood come from the GIT will enter into the hepatic vein, ultimate drainage through the liver cells. Whatever the things in the portal vein are exposed to the liver cells. That's the thing you have to remember. And next one is the hepatic arterioles. There is the most important thing. That is in the interlobular septa. There is interlobular septa. See, supplies in tissues in between the tissues, and ultimately enters into the sinusoids. And it mostly empties into the first 1/3 of the liver cells, distance from the interlobular septa, and this is the area near the portal veins, and ultimately where the liver cell plates from radiating from central vein to the portal vein, portal sinusoids to the portal vein. The hepatic arterioles ends initial 1/3. That is the point you have to remember. You remember this. And this area is very much oxygenated, very much having the blood supply from this hepatic artery. And the area near this central vein is not getting so much of blood supply directly from the hepatic artery. That is the point you have to understand. And this is the area called zone 1. That is the area called zone 1. It is well oxygenated by this hepatic artery, and this is the area called zone 3, very near the central vein, that is poorly oxygenated. And there is a zone 2 in between this well oxygenated and poorly oxygenated directly from this hepatic artery. That is the point of interest that you have to understand it. Zone 1 and zone 2 and zone 3 here. Okay. And with this sinusoids, there is an endothelial cells, and some different Lord cells are there. You can see this is the Kupffer cells. They are nothing but a macrophages that connects to that phagocytes the bacteria, toxins directly from blood from the GIT. So Kupffer cells have the very important function, that is the immune function of this liver cells, It deals with the bacteria from GIT and toxins. So this is the Kupffer cells. And there is a space between these endothelial cells, having the sinusoids and these liver plate cells. There is a space called Dischi, that is called space of Dischi, that is a perisinusoidal space. And this space is most important because this space is connected to the lymphatic system. See, these sinusoids connected to this, please follow me the arrow. The sinusoids connected to this lymphatic system, and that is draining. So whatever the fluid, excess fluid here is drained into the lymphatic system. The liver has much abundant supply of blood flow. There is much abundant supply of the blood flow. So this is the lobular anatomy of liver, that you have to understand this. So what happens? Why you have to understand this? Whatever the blood from GIT goes through this hepatic liver sinusoids and to the central vein and then to the hepatic vein. And any problem with this central vein, liver cells. Hello? Any disturbance? All can mute. Any problem with these cells? And what happens in cirrhosis? These cells going for fibrosis and thickening, and the blood flow from this portal area, portal vein to the central vein, will become narrowed and it's going for increased vascular resistance. That is exhibited as a portal hypertension. Portal venous pressure is enormously increased, and this lead on to portal hypertension. That is the idea. You can understand this pathology, why the portal hypertension in hepatic cirrhosis. Okay. And here there is a blood flow from here, and liver has a very high blood flow and low vascular resistance, and it receives 25% of the cardiac output, and total output, the blood received by the liver is roughly about 130 to 350 ml per minute. That is the 25% of the cardiac output. And the liver has the dual blood supply, that is from the hepatic artery and the portal vein, which I have already seen in this lobule slide. And this hepatic artery supplies only 25%, which you have already seen in this slide, mostly by this portal vein, and very minimal 25% from the hepatic artery. Okay. So hepatic artery 25% and portal vein supplies 75% coverage the blood supply. But the oxygen supply is concerned, and hepatic arteries taking the demands of 50%, and portal vein, even though it is 75%, it is a venous blood, and it covers only 50% of the blood supply. That is the point we have to remember it, because blood flow to the liver is most important in case of deranged anatomy and physiology of the liver. If there is a portal hypertension, increased venous resistance, and blood flow to the systemic component is very much reduced, and the liver is mainly dependent on the hepatic arterial supply of 25%, and any reduction in the blood supply during our anesthesia, already it is in a compromised state. Any of our anesthetic techniques or any other problems on coexisting conditions that will reduce the blood supply to the liver will jeopardize the oxygenation status of the existing hepatocytes, which are all present in the liver and the diseased liver. That is why we are so much bothered about the blood supply of the liver, whether this any drug you can give to anesthesia, whether it reaches the blood supply or not. We are so much bothered. There is the information that physiology that all anesthetists should understand it. This dual blood supply of liver by the hepatic artery of 25% and 75% of the portal system, and the oxygen supply is roughly about 50-50%, 45 to 55 and 45 to 55. And compromise should not occur in hepatic supply because it has a rich content of oxygen. Suppose, and see this, there is an very gradient is there. That is from this portal vein has the venous pressure of roughly about 7 to 9, 10 millimeter of mercury. And this, what is the pressure in the hepatic vein? Hepatic vein, anybody will know this? What is the pressure of the hepatic vein? Venous pressure is almost 0 and 0 to 4 or 5. And there is a gradient between this portal vein and this hepatic vein. This gradient is the driving force for this drainage of this portal blood into the systemic circulation. Okay. So any problem with this increasing gradient, if there is any resistance to the blood flow by means of any fibrosis or nodules or any deranged pathophysiology in the liver, that the flow from this portal side to the hepatic side is deranged and it is decreased, and the patient develops portal hypertension, and this hypertension may be reflected back into where all the situation where the portal vein is in communication or anastomosis with the systemic side. These are all the areas are dilated. That is called the portosystemic anastomosis is exaggerated. Especially the most important organ is our lower esophageal area where there is an portosystemic shunt that increasing the pressure because there is no drainage here, and the pressure is mounted back into this portosystemic shunt areas that will go in for tear and torrential bleeding will occur. It will endanger the life of the patient. That is why there is a portosystemic shunts or we're so much dilated in liver pathology. That is the thing you have to understand. These basic things. And next one is the hepatic arterial buffer response. That is the concept you have to understand. This buffer means adjusting. I have already told that hepatic 25% and portal 75% of the blood flow. If there is any changes in venous flow, cause reciprocal changes in the arterial side. If there is any reduction in the hepatic portal flow, automatically the flow from the hepatic will also increases for the compromise. And there are so many mechanisms involved in this, and there are so many vasodilators are released during this portal hypertension that make the flow to increase to compensate for it in normal physiological states. This hepatic arterial buffer response is compromised in advanced liver diseases. That is why we are so much bothered about the blood flow to the liver. See this figure, there is a most important figure. Everyone has to understand this. I have already told earlier about this zone 1, 2, and 3. See, this is the portal hepatis, where this bile duct and artery and lymph is there. No problem, blood vessels. And this is the area from this is an hepatic arteriole. These are the hepatocyte plates. And this is an central vein. See this is the area where there is an coverage by this hepatic arteriole supplying rich oxygen supply, that is on zone 1 area. That is the cells near the porta hepatis. And the next zone is zone 2. It is intermediate. It will not directly get the blood supply from hepatic artery. That is a zone 2. And there are some cells near the central vein. See this. There is no direct arterial supply. It gets supply from this portal sinusoids. That is an venous blood is the blood supply of this nutrient for this hepatocytes here. And if there is any problem with this least supply and any problem with this hepatic arterial blood flow is compromised, the first area that will be affected by hypoxia affected by this liver cells is zone 3 area, where there is no means area for this blood supply is more compromised. There is the thing you have to remember it. So zone 1, 2, and 3. Zone 1 is rich in blood supply. Zone 3 is very low in oxygen supply. And zone 2 is intermediate. So that is the importance of this hepatic blood flow. Any alteration in blood flow during surgery or any other procedures, you should be very, very careful. And these are all the areas where we have to remember that this all volatile anesthetic that will decrease the blood flow. All intravenous anesthetics that also decrease the blood flow, you should be very careful. And that is why we are using this propofol as the choice of agent for this any patient with a liver pathology, because propofol increases the hepatic blood flow, both hepatic arterial and venous circulation, and suggesting that it has a very significant vasodilator effect. That is why there is the intravenous agent of choice. And regarding this volatile anesthetics are concerned, we will discuss about later in the latter part of the slides, because we don't want to go to the details. And these are all the factors that will decrease the blood hepatic blood flow, and by mechanical ventilation or hypercarbia or hypoxemia or PEEP or hypotension or any hemorrhage or any surgical manipulations that will compromise the flow to the liver. That you have to understand this. You can all those things we will discuss later. And regarding this blood supply of the liver, some of the drugs, that is lidocaine, morphine, and verapamil, labetalol, propanol, they have a very high hepatic extraction ratio. So this extraction ratio, that means it depends on circulation for the metabolism is concerned. And they are highly dependent upon the rate of hepatic blood flow, not because of the metabolism. So the metabolic clearance of these drugs depends on hepatic blood flow. So decrease in metabolic clearance of these above drugs reflects decreased hepatic blood flow rather than hepatocellular dysfunction. So blood flow to the liver is most important for extraction of these drugs. Okay. And the liver is a very good reservoir. It's an expandable organ. We can see that there are so much of sinusoids. There are low pressure area we can expand, and we can have the volume of 450 ml. And if there is any congestive cardiac failure, any central venous pressure increase, there is a backflow in congestive cardiac failure that was reflected back into the hepatic vein and then into the hepatic sinusoids, central vein and hepatic sinusoids, and the liver will expand. The liver will go in for congestion because of this expandable organ. In other way, instead of shock, when there is very low blood pressure, whatever the blood pressure in this liver is shifted into the central circulation, and that will be very useful in instead of hypovolemic shock. So liver is an very good reservoir. That is the point you have to remember it. And that is the relationship between the hepatic venous pressure and the hepatic blood volume. It is not on straightforward direct relationship curve. It can adjust. See, this curve is not straight. It is parabolic, reverse parabolic, and it can elevation and in hepatic venous pressure, they will accommodate more amount of blood, and in case of congestive cardiac failure, what I have told earlier. Though venous compliance is very good, and the role of this picture shows that the role of liver acting as a reservoir. And the ascites will happen. Why these ascites happen? And you have any idea regarding this? I have already explained in this liver lobule slide. Any hepatic vascular pressure and the hydrostatic pressure inside this there are two pressures acting, and this increase in hydrostatic pressure that will increases, that will cause transmission of fluid into the abdominal cavity from the liver and portal capillaries to form ascites. So there is any pressure difference. And another way, there is a blockage of portal flow to the liver, also causes high capillary pressure of the entire portal vascular system and GIT, resulting in edema of the gut and transmission of fluid from the cirrhosis of the gut into the abdominal cavity. That also can cause ascites also. So there is a pressure difference. There are two pressures acting on the vessels. One is the hydrostatic pressure, and other one is the oncotic pressure. And in any liver pathologies, there is albumin production is very low and hypoalbuminemia. The oncotic pressure is very low. That also will cause fluid in the abdominal cavity. That is why when you understand anatomy and physiology, you can able to pursue or explain, you can get it the symptoms due to cirrhosis or any liver pathologies. Okay. That is why I have observed here any pressure inside increase seepage of fluid, there is just backflow into this GIT, and pressure in the system and the GIT is increased, and more hydrostatic pressure and ascites. And I have told earlier about this regulation of this liver, most regeneration. I have already told your capacity to regenerate. You can cut almost 70% of the liver and all will be set right within a matter of 3 to 4 months, and the liver will become back to normal. So the remaining lobes will enlarge and regain to normal size. That is the very wonder of the liver. And these are all the functions. Then only we can, unless otherwise you know the functions of the liver, we cannot able to assess the liver function test. The so-called LFT, we cannot able to understand it. And liver has the very enormous biochemical functions from this protein synthesis. There are so many proteins are synthesized, from albumin to alpha-fetoprotein, and bile formation and excretion, transport, and coagulation factors, and drug metabolism. I will talk about this phase and phase 2 reactions, metabolism of the drugs in the later slides. And waste product elimination, that is mainly this ammonia that is formed by this amino acids and the colons. And this energy metabolism, there is a carbohydrate metabolism, the liver has an enormous role. I will go in detail one by one in the later slides. And hormone metabolism, and most of the hormones are detoxified or eliminated by the action of the liver. Without this, they will cause so much of problems. And I've already told about this immune response that is by the Kupffer cells, by phagocytosis and removal of the toxins. And we'll come into this metabolism, nutrient metabolism of carbohydrate metabolism, amino acid, protein metabolism, and lipid metabolism, and regarding this vitamin. Regarding carbohydrate metabolism, what is there? That is the storage of glycogen. That is roughly about 70 grams per day that was stored in our liver, and it is a ready-made source for release of glycogen to glucose. And our average consumption of glucose is 150 gram per day, and already storage is 70 gram per day will be there for every day, and that will be utilized, will be definitely utilized. And then there is next one is the glyconeogenesis, that is production of glucose by some other sources other than this amino acids and alanine, all those things. That will maintain the blood glucose level. If there is any hypoglycemia, liver is the first doctor in our body to act the immediate release of hypoglycemia in our body. And it will convert other sugars into glucose. That is, glucose is the ultimate sugar we need for energy metabolism by the citric acid cycle. And these are all the major functions in carbohydrate metabolism. Regarding this fat metabolism is concerned, and there is an oxidation of fatty acids to supply energy and synthesis of large quantities of cholesterols, phospholipids, and most lipoproteins are produced by this liver. And it will produce synthesis of fat from proteins and carbohydrates. Excess fat are converted into excess glucose in our bodies are converted into fat. That is done by our liver. And 80% of the cholesterol synthesis in our body is done by the liver. And most of the cholesterol is converted into bile salts. And regarding this protein metabolism, that is a deamination of acids, amino acids. That is the most important reaction from this amino acid to glucose. And with this process, that this urea is formed, and this urea is also formed by this colonic bacteria in this well, and that is transferred to the portal vein to sinusoid to the liver cells, and that urea formation is done by our liver. That is excellent reaction. And the ammonia is very toxic to the cells by means of urea cycle. You have already read in first year, that is now it is gone out to our brain. And forget about this urea cycle. That is the most important thing. By this urea cycle, this ammonia is converted into urea that is water soluble, that is excreted to the kidney. That's what we are doing regularly is blood urea and creatinine investigation routinely to assess the renal function test, how much the urea is cleared out by the kidney or not. Because urea is water soluble, that should be cleared out immediately. And hello, Sandhya, please wait. I'm in class. You can call me later. And the next one is storage function by these vitamins A, D, and B12. And you can store iron as an ferritin also. And it will detoxify many of the drugs also. Next one is this, our drug metabolism by the liver. That is a phase 1 reaction. That is most important one. This that is by the modify the reactive chemical groups through a mixture function oxidases or by this most important cytochrome P54 system. By means of, there are so much of reactions are going on with this phase 1, this biotransformation by oxidation, reduction, deamination, sulfoxidation, dealkylation, and methylation. All these type of reactions are going on in this liver for this drug metabolism, and our barbiturates and benzodiazepines are inactivated by this phase 1 reaction. And this phase 2 reaction that may follow phase 1 or directly going for phase 2, that is a mainly a conjugation reaction with a substance called glucuronide or sulfate or furan and glycine. And these drugs are conjugated with these above chemicals lead on to make the drugs metabolites as water soluble and make these drugs to be eliminated in the urine, or if it is not water soluble, it will make it as a lipid soluble that will be excreted to the bile. Okay, that is the importance of this phase 2 reaction, that is by conjugation. And another special system is the enzymes are there in the liver, that is cytochrome P450 system. There is a principal hepatic microsomal enzymes. There are cytochrome monoxidase, C reductase, and P450. The enzymes converts into polar, that is non-water soluble compounds to water soluble compounds. There are very dangerous thing is that the cytochrome system is capable of producing toxic drug metabolites. That is induced by so many drugs. This system of P450 system of enzymes, there are the enzymes present in our liver that are induced by so many drugs, that is ethanol, phenobarbital, imprasol, isoniatic acid. This enzyme induction of these P450 system that leads to abnormal responses of the hepatic drug metabolism, especially in a patient with alcohol, takes more amount of paracetamol that lead on to acute to fulminant hepatic failure by this induction of this P450 system that lead on to endanger the life of the patient. That is the idea behind this cytochrome P450 system of enzymes. These are all enzyme inducers. These drugs are enzyme inducers for this P450. And the pharmacokinetics abnormalities are there in liver. There is an intrinsic and extrinsic effects that alter the plasma half-life or pharmacokinetic profile of the drugs. The albumin is the principal plasma protein that is capable of drug binding in liver. The albumin levels is very low and the free fraction of the drug is enormously high and lead on to increased duration of action of the bioavailability of the drug is longer and increase the duration, and the unbound concentration of the polar drug is very dangerous. It will produce extraordinary effects. And sometimes it will, in the liver problems, it will increase the sensitivity of the certain drugs. And any liver problems that lead on to hepatic encephalopathy also, especially these benzodiazepines and these opioids. The sensitivity of the drugs are enormously increased in liver. It will alter the pharmacokinetics of the drug. That we have to remember it in liver area. And some of the muscle relaxants, our succinylcholine, you already know. That is metabolized by the pseudocholinesterase that was produced by the liver, and this plasma level of this enzyme is very low. It will prolong the action. Roughly about 5 minutes, the effect is over. It may be prolonged up to 20 minutes, 30 minutes also. Sometimes this may be the cause for this choline apnea also sometimes. It will confuse you. And non-deproducing muscle relaxants used by this area, there is a bile extraction, the metabolism by this bile excretion, that is acronium and rocronium. And unbound fraction of the drug is much more in case of any chronic liver pathology. And these are all the drugs to be avoided. And you cannot eliminate this drug effectively in case of chronic liver problems, any chronic liver disorders. So should we avoid these drugs because of these drugs are excreted by the bile. And some of the hormones and vitamins, and this thyroid hormone conversion from T4 to T3 usually occurs in liver. And for the liver, for this, the liver is most important, and there is degradation of these thyroid hormones occurs in the liver. And the liver is the major site for degradation of insulin and most of the steroid hormones, estrogen, aldosterone, and cortisol, glucagon, and antidiuretic hormone. So hormone metabolism, this degradation, the liver is a more essential organ for all those things. And I already told this is a storage house for so much of vitamins, A, D, E, K, that is a fat-soluble vitamins, and especially this B12 also. The B12 also. And I already told the hepatic production of transferrin and hepatoglobulin is important because these proteins are involved in hemostasis. These proteins are synthesized by the liver, and the ceruloplasmin is important in copper regulation. And the copper regulation ceruloplasmin levels are low. There is a toxicity of the copper will occur. And the next important function is the bile formation and excretion. I have already told you it's an important role. Bile has the important role for the absorption of fat and excretion of the bilirubin, cholesterol, and many drugs. For absorption of cholesterol from GIT, bile is most needed. Otherwise, you cannot able to absorb absorb cholesterol and fat containing, and that will lead down to steatorrhea. And any defects in the bile salt formation and secretion of bile salts interfere with the absorption of fat and fat-soluble vitamins A, D, E, K. Okay. And this is a schematic diagram how the bile is formed, and this bilirubin is formed. There is heme, and there is an old senescent RBCs going for this reticular endothelial system, and they're all destroyed, and biliverdin is formed, and bilirubin is then bilirubin reductase acting, bilirubin is formed, and this bilirubin is conjugated in the liver and excreted as a conjugated bilirubin into the intestine. And here there is an extrahepatic recirculation. Most of the bilirubin is reabsorbed here and entered into the circulation, and conjugated bilirubins are excreted in the urine because it is water soluble. And some of this urobilinogen is formed by this bilirubin by the action of intestinal bacteria, and this urobilinogen is converted to streptobilinogen here, and this streptobilinogen gives color to our feces, and it is excreted through the feces. These are the intrahepatic circulation via this portal system is concerned. In any block is there that we can to identify it by elevation of this conjugated bilirubin or unconjugated bilirubin here. We can set the level of diagnosis where the problem is. That we have to understand this biochemical and physiological areas. And the liver and coagulation, there is the most important aspect that everyone has to understand this coagulation. Why liver is so much involved in this coagulation? Almost all the factors except the factor 8 is produced by the liver, and factor 8 is produced by endothelium. So almost all the factors. And next one is the vitamin K is most important vitamin that absorbs, that it is definitely needed. It is a cofactor for this activation of this vitamin factors 2, 7, 9, 10. And there is a thrombocytopenia will develop if there is any liver problem secondary to splenomegaly, because so much of the platelets are sequestrated by the spleen by means of this portal hypertension. And reduced level of thrombopoietin, that is the factor produced by this liver, synthesized by the liver, which is most important for the platelet production, that regulates the platelet production in the liver. And this antithrombin 3 levels are fall due to, because it is synthesized by the liver. And or increased consumption due to fibrinolysis, and all the proteins involved in fibrinolysis are produced in the liver except this plasminogen activator and plasminogen activator inhibitor, all are synthesized in the liver. So this is an anticoagulant here. This is an anticoagulant. So these levels are decreased. There is all the fibrinolytic factors are decreased going for thrombosis. So the liver problem may cause in coagulopathy by means of bleeding or thrombosis. Both may occur, That is the point you have to remember. Not only this bleeding, coagulopathy. And I have already told this vitamin K deficiency is manifested as a coagulopathy due to impaired formation of prothrombin and factors 2, 7, 9, 10 also. This is vitamin K deficiency. Because why this vitamin K deficiency occur in liver failure and liver pathology? Because the absorption of fat-soluble vitamins needs bile. The bile is not formed fully and intrahepatic circulation is not maintained. The fat-soluble vitamins are not absorbed, and these factors will not, because vitamin K is a cofactor for activation of these 2, 7, 9, 10, and they are become inactive. That is why vitamin K is most important. Either maybe be low production or because of this vitamin K deficiency, these factors are inactive. So these are all the things. Hemolytic changes with the surgical bleeding, and same time it will cause thrombosis, which I already told you because of this bleeding in liver disorders coming for this surgery. Then maybe due to what I have told earlier is this thrombocytopenia, platelet function defects, and that is by platelet aggregation and adhesion problems. And deficiency or decreased levels of these all factors, coagulation factors. And this fibrinogen that is produced by the liver, that may be reduced. It is the factor 1. There may be quantitatively or qualitative abnormalities of the fibrinogen and low levels of alpha-2 antiplasmin, which is an anticoagulant present in the blood. And factor 13 and thrombin activatable fibrinolysis inhibitor and elevated TPA. These are all the causes for this increased surgical bleeding in case of liver problems. So we have to assess all those things before coming to the patient for surgery. And we should have the knowledge regarding this. So at the same time, the patient in liver disease when going for thrombosis, because I already told there is an elevated 1 millibrand factor, that is 1 millibrand factor by the endothelial cells, not by the liver. Because of the low level, this factor is elevated, and elevated 1 millibrand factor creating protease is also elevated, and decreased levels of anticoagulants, that is antithrombin 3, protein C, and protein S, and alpha-2 macroglobulin. These are all the anticoagulants that is produced by the liver natural. And these are all reduced, and these levels of increased level of the balance is not maintained by this procoagulant and anticoagulant. And the situation, the patient will become hypercoagulable and going for the problems of thrombosis and liver disease. Okay. And these are all the coagulation factors you have to remember it, and what is the half-life. And these are all the fibrinogen half-life is 100 hours and prothrombin is 80 hours. For the prothrombin deficiency to occur, it is in early stages. Within 80 hours, the prothrombin in the blood level will fall down. We can assess this, whether the problem is in acute or chronic. For that, you have to know about this plasma half-life of this, all the clotting factors or function, which are all produced by the liver. And we come to the point of this with this overall view of this applied physiology. You can go into this LFT, that is so-called LFT, that is liver function test. You are so much aware about it. Daily, you are seeing this patient in liver cell compromised patients in assessment clinic. We should have the, what I have told earlier, this, what are all the functions of the liver and what are the problems, anatomical problems, and blood supply. All with this information, you have to sit and assess this patient, and you should have the knowledge regarding LFT. LFT is most important because it provides information about the hepatocyte integrity, cholestasis, and liver function. And here the serum is the specimen of the choice, and the blood may be collected in a serum separator, tubes with or without additives. And these liver function tests are neither sensitive nor specific. We cannot come to the conclusion of it definitely, and it will give an idea about it. It will lead you. It will give you. And no one tests, it evaluates overall the hepatic function. We cannot be able to assess the overall functions. So these are all the fallacies of this liver function test. Anyhow, it will guide you. It will guide you to how far the liver is affected. You can have this. There are so many risk stratification systems are there. With this liver function test, we can assess this patient and what is the risk factor for this patient for this surgery by this Stockard-Fuchs classification, Child's Fuchs, and by MELD classification of liver cell assessment, risk stratification. We'll see it later in the next class. And we can combine, it is not the scope of the lecture today for this risk stratification in liver diseases. And then liver function test, there are two things. One is the measurement of dysfunction of the hepatocytes or the biliary system, number one. And number two is the assessment of the synthetic function of the liver. This is broadly classified into these two. And for the dysfunction of the hepatocytes and biliary system, we can do this enzymes, hepatic transaminases, and bilirubin for the biliary system. And for the assessment of synthetic function, we can do this albumin and coagulation factor. These are all synthesized by the liver. Okay, for simple understanding. And these are all the tests commonly done. The test this AST, alanine aminotransferase, and aspartate aminotransferase, albumin, prothrombin time, bilirubin, alkaline phosphatase, 5-nucleotidase, and gum-on-tail transpeptidase. You can go see by this AST and ALT, there is alanine aminotransferase and aspartate. See this, any problem with these conditions, cirrhosis or hepatitis, alcoholic hepatitis, acute viral hepatitis, toxic viral hepatitis, toxic ischemic hepatitis, all these cause increase in alanine and aspartate transaminases at the various levels. See, the toxic or ischemic injury, the enzymes are released from these hepatocytes and it was enormously increased in toxic, and next is acute viral, and next is the order of decrease in descending order of frequency, that is, and next is the alcoholic, and next is the hepatic chronic hepatitis, and next is the cirrhosis. In cirrhosis, the enzymes are not much elevated. So ALT, alanine aminotransferase, and aspartate aminotransferase are sensitive indicators of hepatocellular integrity, and but it lacks specificity. They are also present in muscles of cardiac and skeletal, kidney, and RBC. Also, you cannot come to the conclusion that it is only due to liver problem. The upper reference range is 55 units for ALT and AST 45. And with this, we can able to come to the conclusion. We can assume that where is the problem is, you can take the AST-ALT ratio, it is 2:1. And the levels are normal up to 8 times the upper limit of normal. We can fix this, the diagnosis of chronic alcoholic liver disease. You can take the ratio. And if the ratio is less than 1, that is due to NASH, non-alcoholic fatty liver disease. And the increase in ratio is at least 5 times the upper limit of the normal. And in chronic viral hepatitis and AST-ALT levels are 10 times the upper limit of the normal. And in acute problems, it is when the release is very high and the transaminase levels are very high, and there is more than 28 times the upper limit of the normal. In shocked liver and liver congestion due to some other problem, and ALT-ALT ratio is equal, 1:1, and increase is, shock liver in sense of toxic or ischemic liver injury, that sudden release of enzyme in the circulation, that is 500 times 50 times the upper limit of the normal. But with this aminotransferase, we come to the conclusion of where the problem is. You can able to assume it. And next is the bilirubin, serum bilirubin, the most important thing. Or rather, we can, with this bilirubin, we can consider it with this, whether the bilirubin is conjugated or unconjugated. And conjugated is, we can see with this biochemistry by one positive. That is water soluble, that can be excreted with the kidney. That is another form of bilirubin is unconjugated, that is Vandenberg negative, that is called indirect positive. That is a lipid soluble, and that should be the total of this, it should be less than 1.5 milligram per deciliter. there is unconjugated bilirubin. It is highly neurotoxic and it will high levels may produce encephalopathy. That is very dangerous to brain cells. And we can fix the problem. There is unconjugated fraction of the bilirubin is very high. That is one number negative. The problem is not in mostly in the liver. That is prehepatic. That is due to hemolysis or hematoma or bilirubin overload from the blood transfusion. So if you take this, most of the time you can see in the ICUs that you can take one whole blood volume by 20 pints, and 2 to 3 days the patient will develop what the patient will develop jaundice. That is due to bilirubin overload, and there is a prehepatic. That is not the problem with the liver. The liver cannot able to hold the load of bilirubin that is released from the reticuloendothelial system. But in case of hepatocellular problems, there is a conjugated portion of the bilirubin is very markedly increased. That is due to all what I have said earlier, this viral infection, drugs or alcohol, sepsis or hypoxemia or cirrhosis, whatever it may be. But in case of post-hepatic, the unconjugated bilirubin is increased. But here, this alkaline phosphatase, that is enzyme present in the canaliculi of this biliary system that are released this enzyme, and that is markedly increased. So increase in conjugated portion and alkaline phosphatase, you can fix the diagnosis. It is the jaundice is due to cholestatic, that is post-hepatic. In this way, you can able to come to the diagnosis where the problem is. You can able to judge it at most, at least. I told you earlier, this serum alkaline phosphate, anyhow, it is not specific. It already told earlier, there is canalicular surfaces, this enzyme is present, and this enzyme is increased in biliary obstruction, whether it may be intrahepatic or extrahepatic, whatever it may be. And hepatocyte injury, this alkaline phosphatase may be normal or very minimally increased. And the feature is guide to assess or differentiate whether the problem is parenchymal or biliary. But it is not specific also. It is not specific also. There is a problem. It is found also in the liver, bone, kidney, intestine, and placenta, not only in the liver. So with this elevation, we cannot come to the conclusion, but it will guide you where the problem is. And the serum albumin, this is the most important liver function test. That is most important because this liver produces normally 10 to 20 grams per day, and it will maintain the serum level of 3.5 to 5.5 grams per deciliter. This is the most important parameter to assess this risk stratification in liver patients coming for surgery, and half-life is 2 to 3 weeks. So it's usually in acute liver diseases, in acute fulminant hepatic failure, in a patient, these albumin levels are normal. Because the serum albumin level decreased, that indicates that the patient is having chronic liver disease. There is a thing we have to understand it. Okay. And the prothrombin time and INR international normalization ratio, that is, everybody should have to understand about this. That's the most important point of view. Every anesthetist should be very clear about this prothrombin time and INR. Normally, it ranges between 11 to 14 seconds of control value, but every lab differs. It differs. Some labs shows 16 seconds, some labs shows 15 seconds, and 15 seconds according to the tissue factor they are using according to this ISA value. And this salt liver factor 7 is useful in evaluating the hepatic synthetic functions of the patient with acute or chronic liver disease. And prolongations of this prothrombin time more than 3 to 4 seconds, that is very significant, and it will correspond to increase in IN of more than 1.5. Okay. So 3 to 4 second increase is most significant. And for the normal activity of coagulation, 32, any clotting factor is concerned, that 20 to 30% of the normal factor activity is required for normal coagulation. So the prolongation of the PT usually reflects either the liver disease or vitamin deficiency. Okay. So this is the figure. This denotes that there is a relationship between the prothrombin time and the concentration of prothrombin in the blood. See this. See this. Now what we say, this is an 100%. It is there. The prothrombin time. It is roughly about come to this place. That is 14 seconds. And the prothrombin concentration decreases from the blood from 50%. It is roughly about this one, 20 and 25. So this decrease in concentration, the prothrombin time increases. That is the thing you have to remember. So the prothrombin time is directly related to the concentration of prothrombin in the blood. So the percentage of normal. Okay. These are all percentage of normal. These are the prothrombin time in seconds in x-axis and concentration of percentage of prothrombin in y-axis. Okay. With this, every lab has the values, different values, and we have to standardize it, this prothrombin time, because the tissue factor they are using for this assessing the prothrombin time varies. Usually they are using this placenta that has a varying activity, and we cannot use this for all patients, so we have to standardize it. That is why saying that prothrombin time is not much important, because INR is most important, especially the INR is introduced for evaluating the coumarin activity. This, patient on coumarin therapy, warfarin therapy, they are using this INR standardizing. It is because of the varying activity of the tissue thromboplastin used. We have to come to the point of standardization to measuring the prothrombin time, because each batch of tissue factor assigns the international sensitivity index, that is ISI. And how the prothrombin time is measured in the lab? Anybody have any idea? Any idea? No. So blood is taken from the patient. They will add oxalate and more thrombin. Because why they are doing oxalate? Oxalate is an anticoagulant. So more thrombin cannot be changed into thrombin. That is why they are immediately adding antithrombin. And then they will add large amount of calcium to the blood, because we have to neutralize the oxalate that is added to the sample, and then you can add tissue factor. Usually the tissue factor that is added is placental tissues. So this excess calcium added to the sample nullifies the oxalate. Now the tissue thromboplastin added, tissue factor added, that activates the prothrombin to thrombin by a reaction of which pathway? Extrinsic or intrinsic? Extrinsic pathway. Tissue factor always for intrinsic pathway. Okay. So endothelial factor always for, tissue factor for extrinsic pathway and endothelial factor for intrinsic pathway. So here prothrombin time is an indicator of very good indicator for assessing the extrinsic pathway of coagulation. And the tissue factor activates the prothrombin to thrombin by a reaction called extrinsic pathway. So the time required for coagulation to take place is known as the prothrombin time. And shortness of the time, prothrombin concentration in the blood. According to this, so what is the graph you have seen this, there is a relationship between the concentration of prothrombin and prothrombin time. So what we are doing is we are adding this tissue factor. It has a varying activity. We have to standardize it. That is why the results vary considerably, and differences in the activity of the tissue factor. And the different batches have a different activity. So definitely the standardization is needed for it. So manufacturers assigns ISI, that is International Sensitivity Index, International Sensitivity Index for this tissue factor added for this prothrombin time for assessing, making this, converting into this INR. INR is a mere number, nothing but else. It has no adjectives also. It is a mere number that will give you the assumption that the quality, the indicator of extrinsic pathway, and that indicates the activity of the tissue factor with a standardized sample, this ISI. So this activity varies between 1 to 2, this ISI. So we can do this INR. INR is a mere ratio between this PT of the test of the person and PT of the control value, of the normal value, the lab value. And raises to the power of ISI, that is the tissue factor what we are using this, and we can get the number. That is, with this number, we can assess the quality of extrinsic pathway activity. So the normal range of INR in healthy person is 0.9 to 1.3. 0.9 to 1.3, and this high INR levels or 4 to 5 indicates high risk of bleeding. If the INR value is less than 0.5, there is a chance for thrombosis. So what we have to do, especially this INR is done for specifically introduced for warfarin therapy, but the same thing can be applied to all this liver function also. This INR of 2 to 3. So we have to make this INR to normal, bring down the INR to normal by less than 1.5, that is normal. Okay. For warfarin therapy, we have to maintain this INR of 2 to 3 for preventing thrombosis in when it is indicated. Anybody have any idea on warfarin? In mitral stenosis patient with atrial fibrillation, they are more prone for thromboembolic manifestations. You have to make the INR level of 2 to 3. For any patient on warfarin therapy, you have to check the INR every month or to assess the quality of the efficiency of warfarin. Okay. So in a nutshell, the prothrombin time indicates the concentration of prothrombin in the blood. That is the thing you have to understand. And next one is this blood function LFT, that this one is added. There is a blood ammonia estimation. And this is most important, that I already told earlier, this ammonia is very toxic to neural tissues that will lead on to hepatic coma. So this normal value is 45 to 65 millimoles per liter, and mark elevations and reflects there is a severe hepatocellular damage and lead on to encephalopathy. So this ammonia estimation is also important. That is, next one is the TEG. It is not a liver function test, actually routinely employed, but it is used to assess the coagulation status of the patient, liver disease patient on chronic liver disease, or patient on liver transplantation, on any major liver surgery patients. There's a gross alterations in the hemostasis in liver pathology. You're subjected for long surgeries, prolonged surgeries, or major surgeries. So this TEG is and thromboelastography. There is a point of care viscoelastic coagulation monitoring. You can global assessment of this coagulation system. You will assess the procoagulant and anticoagulants in the same time. It's a real-time assessment. It is a new technology that provides the real-time assessment of the coagulation analysis to assess the global coagulation. That is it will assess the platelets also, all the clotting factors, all the anticoagulants, antifibrinolytic factors, all can be assessed in a single time. And it's a real time, it will give the results within a matter of 30 minutes. And according to this, you can act. Which component is needed, you can do it immediately and the problem is settled. So it shows the interaction of platelets with the coagulation cascade, aggregation, clot strengthening, fibrin cross-linking, and ultimately fibrinolysis. So it does not necessarily correlate with the blood tests as CyanR or APTT or platelet count, which is often poorer predictors of bleeding and thrombosis that will cheat you and intraoperatively. So this is a real-time assessment of this thromboelastography. The knowledge regarding this thromboelastography is important, and you are giving anesthesia for major liver diseases and going for major surgeries. And this is the schematic diagram of this PEG machine, where the pin is there that is attached to the transducer. Okay. With a torsion. And there is an oscillating cup. The blood is, whole blood is poured inside of a small volume, 0.3 ml, 36 ml of whole blood. Clotted blood is here. And this, it will rotate. The pin will rotate, oscillates. And this torsion wire is connected with a mechanical transducer. Where a pin is suspended. This pin is suspended in a cup. Okay. So as soon as the switch is on, it will start. And the elasticity and strength of developing clotting changes. That rotates the pin, which is converted into electrical signals that computer uses to create a graphical and numerical output. So with this, it will give a graphical output of this, the global coagulation functional analysis. And with this, within a matter of 30 minutes, there is a point of test. It will click and we can act according to the values obtained. It will see the real-time conditioning of the coagulation system. So this is the figure that is delivered by this pin. It is a mechanical power is delivered, and this figure is electronically printed here. They will show you, and there are so many components are there in this picture. There is an R time, there is a reaction time. There is a first significant clot formation, and this is the K time that shows the firmness of the clot. And there's an angle, there is a kinetics of the clot development, how fast it develops into a clot, and the firmness, how firm it is. And this is the angle, that is called the alpha angle. And there is a next factor, next component is a MA, there is a maximum amplitude that denotes the strength of the clot, how strength the clot is. And from this clot is formed, then the coagulation is over with this point of time by these procoagulants. And next it will assess also the clot lysis will occur due to fibrinolysis. And that is after the 30 minutes. And the percentage of lysis in 30 minutes after MA, that shows the strength, how far this fibrinolytic activity is going on. We can able to assess it. So first is the reaction time in minutes. There is a time between the initiation of coagulation cascade to the initial formation of the fibrin. And next is the K time. There is a time taken for initial formation of fibrin to specific clot firmness, that is 30 millimeter. And there's an alpha angle. There is the rate of fibrin formation and cross-linking. And maximum amplitude MA, which I showed earlier in this picture, MA. And there is a maximum strength of the clot, and next one is the fibrinolysis, 30 minutes after maximum amplitude. How much the fibrinolysis will going on? There is a clot lysis. So with this OR time is clot formation time is 5 to 10 minutes. If it is there, if there is any problem with this, you can give this coagulation factors only. The treatment is FFP. If the K time is prolonged, it is a time until the clot reaches the fixed strength. The strength The strength is not there. Clot strength is by this fibrinogen, fibrin to fibrin polymers, cross-linking fibrin monomers to polymers, increasing the clot strength. If it is not there, the fibrin, you have to give fibrin that is enormously present in cryoprecipitate. The treatment is cryoprecipitate. You have to give it immediately on the table. And in alpha angle, that is speed of fibrin formation, how fast it is done. That is by this angle, that is normally 70 degree. If it is slow, there is again the fibrin is the problem. The treatment is cryoprecipitate. And MA, that is the vertical amplitude of the TEG, that is the firmness of the clot. That is by the platelets. And the platelet will strengthen the fibrin polymers. If you read this physiology of the normal coagulation pathway, the platelets have the major role in firmness of the clot. And if it is this MA is reduced, the platelets are not effective and inactive. So the therapy is platelets. This MA and clot lysis is not go. It's excess fibrinolysis. It is more than this. It is so lengthy that doesn't you have to give this anti-fibrinolytic agent that is tranexamic acid. So this is the way we have to assess the global assessment, real-time global assessment of the coagulation cascade. Okay, that is why the TEG is more useful in intraoperative management of coagulation system failure. This is the thing, it is repeated, what I have told earlier. Arterial prolonged FFP and MLO, there is cryoprecipitate, fibrin is less than 20, cryoprecipitate, platelet less than 50, platelet transfusion. And this clot lysis, prolonged lysis is going on. There is, you have to give this anti-fibrinolytic agent should be done, that is the patient is going for DAC. That you should have to keep it in your mind. This is the way we have to interpret this thromboelastography. Based on this, you have to give the therapy, then and there. Okay. That knowledge regarding this thromboelastography is most essential for the anesthetist concern. So see, this is the pictures done by this thromboelastography. Anyone can able to diagnose what it is. The first figure, that is normal. Every R time, K time, MA angle, everything is normal. And second day, see prolonged R and prolonged K. See this R time and K time. See this figure, very prolonged compared to this. So what is the anticoagulants? Is the problem? So you have to do FFP. MA angle decreased. And this patient had platelet blockers, dual platelet blockers, antiplatelet agents. The TEG figure will be like this, and MA is reduced, maybe due to thrombocytopenia or thrombocytopathy. Try to give platelets. And see, this is a fibrinolysis. This is okay. This time is okay, and there is a prolonged fibrinolysis. It is an presence of TPA. And what is this one? Any idea? Figure is very large. There is hypercoagulation. R and K, immediate coagulation. Hypercoagulation, R and K decreased. MA angle is increased, very strong clot formation. And initial stage of DAC, there is an hypercoagulable stage. Hypercoagulable stage. So this MA time is increased, everything is reduced. There is a initial stage is consumption coagulopathy. All the coagulation factors in the body is consumed in the early stage. So DAC in the early stage is hypercoagulable. Followed by secondary fibrinolysis in stage 2. See stage 2, there is a fibrinolysis. There is no clotting. There is only fibrinolysis and bleeding everywhere. So in this way, we can able to diagnose this DIC and all the clotting problems in a global assessment of the clotting system. With this, we can able to So diagnose earlier and we can treat the patient immediately. We can restore the problem. Okay. And effect of anesthesia on hepatic function. Some few points about this. We are going to finish this. It is the time is very over. I think 9:45, 9:25. And hepatic blood flow is most important thing that during this regional and general anesthesia that will be decreased. There are multiple factors are responsible for it, for the both direct and indirect effects of anesthetic agents and the type of ventilation employed and type of surgery being performed. So decreased cardiac output have the reflex sympathetic activation, which vasoconstricts the arterial side and venous splanchnic vasculature, lead on to reduction in blood supply to the liver. And the hemodynamic effects of ventilation has the impact on hepatic blood flow because these are positive pressure ventilation and high mean airway pressure reduces the venous return to the heart and decreases the cardiac output that compromise the blood flow. And any surgical procedures near the liver can reduce the liver blood flow. Why up to 60%? Why there are so many theories are put forward? Is still not at all come to the conclusion. Any surgeries near the liver will reduce the hepatic blood flow, and mechanism is not clear. Most likely involve sympathetic activation, local reflexes, and direct compression of vessels of portal and hepatic circulations may retard the blood flow to the liver. And these drugs, beta-adrenergic blockers, alpha-adrenergic agonists, and HM blockers, and vasopressin, these are all the vasoconstrictors that will reduce the hepatic blood flow, and low dopage infusion may increase the liver blood flow also. So with this carry home message, come to the end of the session today. It is a long, lengthy lecture, I think. So understanding the liver lobule anatomy, generally you can understand liver pathology. The portal system, hepatic vein, sinusoid, central vein, hepatic vein, all those things. And gradients from portal to central vein to hepatic vein. Any resistance of food lead on to portal hypertension. I have very well explained. Please have the knowledge about it. And hepatic blood flow, anesthetic implications very important. And the dual blood flow of the liver, that is by the hepatic artery and portal vein, and regarding this oxygen supply, and liver as a reservoir in shock states and also in volume overloads, and so many functions of the liver, metabolic functions, I already told you extremely, and synthetic functions, knowledge regarding this, then only you can interpret and assess the liver pathologies coming for your assessment clinic. And drug metabolism regarding this anesthesia is concerned, should be very careful. And liver coagulation, liver and coagulation, most important thing, which I have told enormously, almost all the clotting factors except 8 are produced by this liver. And this coagulation and liver both have this, we can have this bleeding as well as thrombosis. That is the dual effect of this liver pathology, where the pathologies you have to consider about it. Should have the knowledge regarding it. Never think only about the bleeding only. And you can have the sound knowledge regarding this liver function test. I have already told earlier, you can go and read today the liver physiology and liver function test, and almost the STEG also. That this is the right time to interpret the STEG. I have opened the knowledge regarding the STEG for you, and that will. It is the global assessment of the procoagulant and anticoagulant in real time manner, and you can treat them, you can diagnose them immediately and treat them efficiently on the table in preoperative status of the patient. Okay, with this I will conclude. Thank you. Thank you so much.